Welcome to Detangle, where we untangle the complexities of life, one conversation at a time. Today's discussion will be a truly heartfelt one, for we have with us Dr. Tiny Nair, a renowned cardiologist from Trivandrum. I'm your host, Dr. Kinjal Goel, and I'm so excited to have a cardiologist with me today. My introduction personally to Dr. Nair was through his writings on Cora. A prolific writer and a recipient of several awards, Dr. Nair is an inspiration to many. In his own words, he comes from a multicultural family, a Bengali mother and a Malayali father, thanks to which he enjoys everything, from rasgullas to filter coffee. He is also a travel enthusiast and enjoys exploring new places. Welcome, Dr. Nair, and thank you so much for joining me on Detangle today.
Thank you, Dr. Kinjal, and thanks for the nice introduction. I'm so happy to be here with you tonight.
So, Doc, without wasting any further time, let me dive into the questions. I have lots of questions for you. There's so much I want to ask, and I'm sure there is so much that our audience wants to know because the heart and mind, they have a very special relationship. So, here goes. Doc, in your bustling practice, how often do you see emotions playing a strong role in a person's cardiovascular health?
Dr. Kinjal, I think that's a very interesting question, and the answer is not really very simple. Uh, Emotions are present every moment of our life, right? For example, I always compare emotions with a placid sea. You look at the center of the sea; it's so placid. You focus on the shore, you see those waves lapping on the shore softly. They're like our daily emotions, right? A bit of happiness, a bit of sadness, a little bit of anger. Maybe you are upset about something, you're warmed. Everything is like that sea with a little bit of uh, those lapping of the waves at the shore, right? But sometimes, without a notice, you see a tsunami coming in, right? A storm raging and huge waves. And that is when emotions rage. You get extremely angry, you're extremely upset. And that's it's all about. But when we talk about our daily emotions, the little bit of sadness, happiness, and all that, understand that our cardiovascular system, the heart, is governed by a complex set of nerves, a set we call as sympathetic, meaning that they are like your car's accelerator. They accelerate stuff. They increase your heartbeat, your blood pressure. And on the other side, we have what we call as the parasympathetic, a brake. Slows down our heart rate when we go to sleep. And this combination, this fine tuning of the accelerator and the heart is what keeps the heart ticking at the right rate and the right programming and the right way we want it to, right? Now the point is if we take a cardiovascular illnesses, let's take the most trivial one.
Mm-hmm.
Someone walks to my clinic with a high blood pressure, right? A young man, he may not have a blood pressure. He might be simply anxious, and we are getting a higher blood pressure reading. And that might be what we call it as white coat hypertension,
Mm-hmm.
simply anxiety driven. So, on one side, you have trivial things like so called white coat hypertension. On the other hand, on the other end of the spectrum, Dr. Kinjal, we have a large study from US which shows us that people who leave the intensive care unit after a major heart attack, let's say massive heart attack, one who leaves the intensive care unit extremely worried and anxious, he doesn't do well at all. In contrast, one who leaves the ICU with a similar kind of heart attack, a similar kind of damage, but he's kind of cheerful, he does better, not just a short term, but years after the attack. So, emotions play a significant role in almost every case of not just health or mild disease. I think every sphere of cardiovascular abnormalities that we see in our daily practice.
I think that's one of the most impactful analogies that I have heard about the heart and mind. Because, like you said, it's always present, sometimes high, sometimes low, but we never really spend a day without emotions, do we?
Correct, absolutely.
So, Doc, there is a commonly used term. I'm sure all our listeners have used this term at least twice in the last week. The term is heartfelt emotions. It means something rather simple to most people, but for you and for me, it runs a lot deeper. Can you explain how these intense emotions can actually be felt physically by the heart?
Yeah, I think that's very, very interesting. Uh, See, I always, in my lectures to my students, I always refer to as we have two hearts. So students are surprised. Two hearts. Yes, we have two hearts. One is a heart that I and both of us we see every day. One with four chambers, four valves, arteries, veins, muscles contracting. The physical heart, right? We listen to it with the stethoscope. We try to diagnose problems by an EKG, echocardiogram. We try to remove blocks, replace valves, improve its functioning, put devices. That is the physical heart that the physician, that the cardiologist treats, right? But there
Right.
is something else too. And that is kind of the second heart is the philosophic heart, right? People say that, oh, I was heartbroken when she left me, or, oh, my heart filled with happiness. They're basically referring not to the physical heart, but to the mind. And this connection of the heart with physical, these two kinds of heart, the mental heart within quotes and the physical heart, is not simple. In fact, if you study history very interestingly, in old days of Rome, the Roman Empire, it was believed that there's an anatomic connection, and people believe that there's a vein
Mm-hmm.
that carry blood from the ring finger right straight to the heart. And they said it's called vena amoris. Vena amoris carries blood from the ring finger to the heart. So that's why you still put the engagement ring on your partner on the ring finger, thinking
Right.
that will straight go to his heart. Okay. We
True.
today know it's wrong, but it's not just anatomic, but think of the physiology connection. Uh, our brain secretes a lot of these neurohormones, right? They are catecholamines, epinephrine, norepinephrine, your dopamine. These ones stimulate the heart, right? They increase the heart rate, increase the blood pressure, and a person who is exposed to a surge of dopamine or noradrenaline feels what? He feels palpitation, he feels giddy, he feels his effort tolerance has come down. We have a term called panic attacks. And if you
Right.
see a patient of a panic attack, it looks exactly like a heart attack. Right. He comes with sweating, chest discomfort, clutching his chest, his heartbeat, which is faster. And to the physician also, we sometimes think, is it a heart attack? Am I mistaking one? And it might be simply a panic attack. So you see, these two hearts connected together in a very close way, and they are interdependent and they operate rather mysteriously together.
True. I think this is a simpler way of understanding the overlay between the heart and the mind simply by placing the heart itself in two categories. But yeah, it does make it simpler because all of us at some point have felt this, that nervousness when we're about to go up on stage, or, that excitement when you're going to meet somebody you like. So your heart reacts before you even know what is happening. So, yes,
Correct, correct.
the philosophical and the physical heart interacting. Talking of which, you just mentioned somebody having a broken heart. So, this broken heart syndrome is something I find very intriguing because this is the epitome of the physical heart reacting to emotions. Can you tell us something about this cardiomyopathy?
See this broken heart syndrome, also going by the funny name called Takotsubo syndrome. If you Google, you'd find
Right.
Takotsubo syndrome. It's this stress cardiomyopathy. It's a very interesting term. People ask us what is Takotsubo.
Hmm.
Takotsubo is an contraption used by the Japanese fishermen to catch octopus. And quite
Right.
simple, but ingenious. It has a very narrow neck. It's a leather pouch with a very narrow neck and a large belly. Looks like those ladies' purse, where you pull the strings and the purse neck narrows. So they're hung at the depth of the sea, and the
Hmm.
poor octopus comes and swims in because the neck is narrow. He just goes in, and as the octopus goes in, he realizes that he's in a closed belly of that bag, tries to turn around with all its feet and all that. It tries to wriggle, and the string becomes tighter and tighter, and it automatically traps the octopus. So it's simple. You put it down, and once the octopus is in, you just pick it up and go home. So simple, right? Now,
Right.
the name comes to cardiology because the main pumping chamber of the heart, the left ventricle. If you look at the left ventricle, in Takotsubo, the stress cardiomyopathy turns exactly like that Japanese contraption, Takotsubo. Okay, let me tell you about a case. This happened just about last month. Young lady, uh,
Hmm.
30s,
Okay.
30s. She lost her husband. Actually, he died in a road accident. So
Hmm.
when the news came back home, she was upset. You can understand a young wife losing her husband, and she was crying and she was grieving. And then she said, I have chest pain and I'm feeling bad. So obviously, relatives brought her to the hospital ER, and everybody knew that it is stress induced. She was given some stress relieving medications, some diazepam, and she was kept there for observation. But she still went on complaining, my chest discomfort doesn't go. So, uh, an intelligent resident in our ER, he thought, why not do an EKG? Did an
Hmm.
EKG, and that showed surprisingly a massive heart attack.
Oh,
So we were called in cardiology heart attack. So we went in, and as the algorithm runs, young lady heart attack, shifted her to the cath lab, did an angiogram, and to our surprise, the angiogram was normal, no blocks at all. So
interesting.
surprising, right? Yeah. So normal angiogram, a lady getting an EKG exactly like a heart attack. And then we knew, oh my God, we were missing something. This is stress cardiomyopathy. Okay, and we had a look at the echocardiogram. The echo showed the classical Takotsubo syndrome, meaning that the left ventricle showed the narrow neck and a large belly, which normally is an oval shape and contracts. Well, this is barely contracting. We knew it is Takotsubo syndrome. Admitted her, treated her, and fortunately, she is fine. Now the point is, for a long period of time, even we said that Takotsubo is just one-time affair, comes and goes, and once
Hmm.
you're all right, you never get into a problem. In fact, a very recent publication from Great Britain shows that it's not. Actually, the
Really?
data shows that, yeah, it shows that there is a very high chance of recurrence if these women, mostly it comes in women more than men, if they are exposed to a high stress again. They might get another recurrence of Takotsubo, and that might be worse than the first episode. So I think these are people who are very susceptible to stress, and we need to be careful. We need to be cautious treating them so that they don't get into a recurrence again. So I think the point to take home is that, like we said, a sea, calm sea is nothing. But when there's a tsunami, a
Hmm.
emotional tsunami that might secrete huge amount of catecholamines like adrenaline and noradrenaline, and that surge might damage the architecture of the heart, the very delicate vascular system of the heart. The blood vessels going to spasm, and that is the pathobiology of how a Takotsubo syndrome takes place. Very, very interesting.
Really, I think this is so, it's so physical, it's so visual, and it's so real that it just brings everything together in the most magical way.
Yeah, in fact, there have been reports where people have gotten Takotsubo after winning a lottery. So
Oh,
even too
really?
much of, too much of happiness might bring in Takotsubo. So I think as
Oh,
long as
this
you
is
are
new.
fine,
This is
okay,
amazing.
yeah, interesting.
Very interesting. Doc, we also, I remember when I was studying, what was more popularly known as type A and type B personalities were of great interest in cardiac psychotherapy. I'm sure you've also been using type A, type B
Yeah.
to identify patients. But now psychologists at least are focusing more on the type D personality, especially in understanding outcomes of procedures for pacemaker implants or ICD implants. Do you deal with type D as well?
Yeah, I think a little introduction for people who have not very conversant with ABCD like you and me. Type A, we have these personality traits. And the way it was picked up was that in most cardiologists, busy cardiology practice outpatients, it started in San Francisco, where Dr. Friedman's OPD, they found that all the chairs' fronts and their handles were damaged as if they were eaten by beavers. They used to call it beaver eaten. So, and that was because patients were anxious and they were gnawing at the chair handles and they were sitting in the front, damaging the upholstery. So, type A is one where people are like, go getter. These are people who don't sleep. They want to get onto the top of a cliff. They see
Hmm.
the next target and go, and they're just go getters, right? That they're adrenaline driven. But the problem is, type A, when they don't get something, They get easily frustrated. They get angered very soon. Their social relations are bad. That is type A.
Right.
Type B is just in contrast, like happy go lucky, okay, vacation type, relax, go out with the family, enjoy yourself, and that kind of stuff. And is somebody who is cautious, who is careful in their every step. That is C. And D is something that is new. D is where a person is continuously stressed out, whatever be the background, they are stressed out. And this stressed background, you can actually start thinking that in your office, in your school, in your neighborhood, you have people like that. You find them extremely stressed out at small trivial things. Like they're never relaxing. They're always thinking, oh my god, this is what. They're anxious, they're angry, they're depressed, they're always worried. Now these deep personalities tend to obviously get more of heart disease, as understandable. uh,
Mhm.
and now, we are now, those who are unaware about pacemakers and ICDs, for example, intracardiac defibrillators are put for people who get an cardiac arrest to prevent another cardiac arrest, right? And now we have got one step forward and trying to think that if a person is highly susceptible to a cardiac arrest, why not put it earlier? But understand that these are complex machinery you are putting by a surgery inside the chest, and so people are careful about it. Now, so the thought process is that if we think that a person is more prone for heart disease or a cardiac arrest simply because he has a particular personality trait, can we use that as an algorithm to tell us that this person is more likely to get a cardiac arrest? And I should probably have a lower threshold of putting in an ICD. Now the answer is not very clear. If you look into
Mhm.
the all the international guidelines by all our ACCs, AHAs, and ESCs, we even the Indian guidelines, we don't really recommend that let a personality type decide conclusively on whether you need to put on a pacemaker or an ICD. But yes, we should understand that when we are looking at type D, we are looking at somebody who's stressed out, and obviously this anatomic heart has a higher chance of getting into trouble, and we need to take proper steps to prevent that.
Doc, let me share this very interesting bit of information that I usually deal with. When a patient has to have an ICD implanted or a pacemaker implanted, and when that patient also has a type D personality, they are more likely to reject the implant or not do very well with it, even if the machine is working beautifully. So now what we do is we try to get these type D patients from the cardiologist if they really do need the device and help them through therapy before the device is implanted so that there is a better outcome. So these algorithms are constantly evolving, and it's very interesting to see that the outcomes are improving.
Correct. With this, we see even for example, bypass surgeries, right? There are patients who have a severe triple vessel disease. We do a bypass, and we are kind of relieved. Oh my God, he was on the brink of an heart attack, and our bypass surgery saved him, right? And
Right.
the patient would come for follow up and say, "See, doc, I have a big scar in my chest. Can't you see that it's
Absolutely.
so ugly?" So from our perspective, we think, "Oh my God, is it not foolish to think that he has a scar, but we have saved his life?" But the type D people are always upset and always critical of everything that is being offered to them. So I think we need to prepare them better, understand that it is not their fault, right? It is
Absolutely.
the mind is just like any other body organ. So we need to correct that before we go in for a major therapy like an ICD, a pacemaker, or a bypass. Like you said, they are the people who are likely to reject implantation in the first place.
Very interesting. I think I'm enjoying this whole revelation of what goes on behind your desk and what goes on in front of your desk. It's a very visual experience even for me to see how much you see and experience of a patient, not just from a cardiologist perspective, but also from a psychologist perspective. I think every cardiologist is playing the role of a psychologist subtly at all times during his or her practice. So there's this particular set of symptoms, doc, which come very frequently. I don't know how much you have seen these to be falsely clubbed, but a lot of patients will come and assume that a mild to moderate spike in blood pressure has caused headaches. They actually make
Yeah.
it like a causative affair. This has caused that. When in fact, sometimes it is more likely that an external stressor has caused both the headache also and the increase in blood pressure also. I mean, I've had patients come and tell me that When I have a headache, I check my blood pressure. It is high, so I take a blood pressure medicine. So,
Yeah.
can you kind of, unravel this for us?
I think this is interesting because whenever we check a blood pressure and find the blood pressure is high and tell somebody, see, I think you have high blood pressure, the first response is, but doc, I don't have headache. I never have a headache,
Also, you
right?
see the
So,
other angle
yeah,
also.
the other end of it, right? Exactly opposite of what you said. And we obviously see patients who come and the husband would say, she always has headache. And, doctor, I think she has high blood pressure. She gets angry with me for small things. I don't tell them that even my wife gets angry at me for small things. But the point is that these things are not a symptom of high blood pressure, right? High blood pressure in 95% of cases are silent. It has absolutely no symptoms. Okay, excepting those maybe 5% where it might be a severe hypertension causing leakage of fluid in the brain, what we call as hypertensive encephalopathy, or this hypertensive patient has a very mild stroke or whatever. Otherwise, uncomplicated hypertension has absolutely no symptoms. So, right on the point, as you said, when people have a stress, their
Mhm.
blood pressure goes up, they also get what we call as tension vascular headache or stress headache. So when they come to a doctor, he complaining of headache, the blood pressure is also elevated, and people tend to connect it. So I think there the importance lies in trying to tackle the stress rather than trying to treat the blood pressure with medications. You are absolutely right on point. It is exactly like we discussed the panic creating a symptom of heart attack. Where there we don't treat the heart attack, right? Where there is no attack at all. We treat
Absolutely.
the stress that drives the panic.
True. So, Doc, in your practice, when you have a patient who comes and you have identified this patient to have more psychological issues than anything else, what is your next step? How do you refer them out? Do you refer them out? How do you deal with
Uh,
them?
I think that is a real bad problem. It's a big headache for us. And I think we are doing very bad in that area. Uh, let's say a patient comes, we have a physical disease. We are good at it, right? We treat it. But when we don't find a physical ailment or there's an overlay of non-physical components in it, we what do? We say, you don't have a problem. Okay, and he comes
Mhm.
back again. We tell him, you don't have any problem. I told you last time. He comes back again and he's frustrated, right? And a couple of visits later, we are frustrated too. We don't know what to do. And we send him telling that you have no issues. And finally, when we are pushed to the wall, we say, okay, refer to psychiatrist. And he says, what, doc? You mean you think I've lost my mind? So,
Mhm.
in India, when we talk about a psychiatrist, people take it very badly. They think that you are thinking that he has lost his mind and there is some bad mental disease for him. He thinks that can it run in families? There are so many wrong concepts. So we are stuck. One, in a busy OPD, we don't have enough time to spend with our patients and actually uh, handhold them, telling them there is no problem. And on the other side, we can't really refer them to a psychiatrist. I think every cardiology unit should have a counselor who should talk to the
Absolutely.
patients, and actually tell them. I think then and then only our treatment is going to see the real effect. Physical disease is what, 50-60%. Rest of it is how the person feels. Exactly like I told you, the patient who has gone home with a successful bypass surgery is still bothered about the scar. So unless we can convince him that this is nothing, nobody is going to look at your scar. You got back your life. And that little statement, that little hand holding, our cardiologists are not good at all. And I think we need to improve. If you ask me, are we doing well? I don't think so.
Well, I'm glad you actually said it because when I talk to others about this, there is a lot of camouflaging happening. A lot of people are trying to pretend that we are getting over this taboo when in fact we are not. We're doing very badly, like you said, in this area. And one of my pet peeves is when a doctor tells the patient, look, it's nothing, it's just stress. That kills it because there is no validation. The patient feels like he or she is being called out for being fake. And everything that a psychologist might have been able to do crumbles right there. So I certainly hope that we are able to build this kind of information base or this kind of awareness in doctors and patients alike that this can be dealt with such certain kind of kindness, with understanding,
Absolutely,
with awareness.
absolutely. Dumping everything onto stress has no value. It spoils the whole thing. He thinks that it is like, we say that if your sugar doesn't come down, next time we will give you insulin injection. So we are creating a terror of injection in him, right? He will never
Right.
accept insulin in his rest of his life. Similarly, if we put that you are stressed out, so when we lose contact instantly.
True. So now let me come to a very personal question with you, Doc. Whenever I have a guest on my podcast, I ask them. Most of us have a physical first aid kit at home, right? We have some band-aids in it, we have some paracetamol maybe, we have some basic things that we might need if we have some cuts and bruises. Let's say if you were to make a mental first aid box for yourself, something which you could just open if you've had a bad day, if you've had a fight with someone, some kind of little trauma that you want to get over when you come back home. What would you put in that box? What would you put inside which would make you absolutely happy when you open it?
I think that is a difficult question. To be very true, I don't have a first aid box. But two things that I always tell my friends, my family, my patients, and I always tell myself, right, in so-called bad days, is this. I tell all my friends that, let's say tomorrow morning, unfortunately, you're diagnosed with an end stage cancer, right? It
Mhm.
can happen to anybody. It can happen to you. It can happen to me. It can happen to anyone, right? And then we are just, all our perspectives are gone. Our Facebook likes are gone. Our movie theater tomorrow is gone. Our all our plans visiting the shopping mall is gone. Everything is gone, right? Our perspective is, can I somehow get out of that cancer, right? And let's
Right,
say a new therapy gives you a relief, and you say, oh, I got cured of my cancer. I'm back to normal. I'm so happy. I'm so happy that I'm back to normal, right?
right,
So I tell people and tell myself that I don't have cancer today. I don't have a deadly disease that's going to kill me tomorrow. Without that, why can't I be happy, right? Do I need to develop a disease, get rid of it, and get back to what I am, square one today, and tell myself that I'm happy? So mornings, like you said, on a day when I don't think well, I think, okay, right, let's look at the good things. I still don't have a disease that is not going to kill me today, right? Why can't I be happy? That is point number one. And second thing, it's again a small thing that I always tell is that people always say that, oh, I have a bad relationship, my family had a problem, my workplace has a problem, or my school or a college has a problem. I tell them it is not that which is driving your unhappiness. It is
mhm,
your reaction to that environment which is responsible for the trouble. Don't blame the environment because it is your response. So I tell people, people always find me that I always smile in the OPD even at evening 3 o'clock after 45 patients. They come and patients come and tell me, Doctor, you have been working since morning. How are you so happy? And I said, see, it is all a question of your reaction to the environment, right? You can come and tell me anything, but you can't actually insult me without my permission. And that would be the second, if at all, the last toolkit in my my
mhm.
mental first aid box.
Well, that's a very beautiful perspective. It's a very philosophical way of putting it, but yes, it works. These thoughts can be extremely powerful if we stick to them and if we make them an attitude. So, thank you for sharing that. As we come to a close of this podcast, Doc, there is something I always leave open for my guests. Any question that you have for me as a psychologist?
Yeah, please tell us some tips and tricks of how we can take the so-called stress or the unhappiness uh, from the patient's mind or whom we consult, and how can we make our relationship, the patient-doctor relationship, more cordial. I think we all have our own techniques, but it is always to learn from something, a person, a professional like you, so that I can remember it.
To begin with, I think stress is something which we all underestimate. For most of us, we believe that, oh, it's stress, it must be in the mind, stop overthinking it, including doctors. So I always tell the doctors that I work with or the consultants that I speak to that consider stress to be as real as the physical disease and validate it. Once a patient feels that the stress causing the symptom is as real as maybe an organic thing causing the symptom, they are more likely to accept it and to move on. What usually
Correct.
happens is you tell a patient they have migraine and they're very happy to take the diagnosis back because they can say something to their family, right? Look, I have a migraine, let me sleep. But if you tell them that, look, you're overthinking it or you have stress and that's causing your headache, the next thing you know, somebody in the family will say, I already told you, you think too much. So it becomes a blame game. So it's very important what the doctor says to the patient, even in front of the family, because that's how the treatment then goes on at home. So if you tell your patient that stop working so much, stop worrying so much, just relax, that's exactly what the patient's family is going to tell them later. Listen, relax, nothing is happening to you. But if you say, look, I see your symptoms and I understand what you're going through, let's take a psychologist or a psychiatrist's help to get you over these symptoms, they'll feel a little
Correct.
more validated and respected.
Correct. Absolutely. Absolutely.
Well, Dr. Nair, it has been an absolute pleasure talking to you. I never realized that cardiology could be so visual. I mean, there could be so many analogies that you could create in your mind. You've given us some beautiful thoughts to go back with. And I'm sure that a lot of listeners will keep going back to this episode to try and understand what part of cardiology they were missing out on. This will help not only patients but also caregivers in understanding how to take care better of themselves and of others. So I'm really, really grateful for your time. I'm really grateful for your expertise and your advice. Thank you for being on Detangle and thank you for making this so special for us.
Thank you, Dr. Kinjal. Enjoyed the evening. Enjoyed it absolutely.
Thank you.